Hi, I'm Richard Hines. I'm a systems designer working on structured decision architectures. In this video, I'll show you how an architecture called the Emergent State Machine can help reduce alarm fatigue and provide more meaningful signals in clinical settings. Imagine you're standing in a patient room in an ICU or emergency department. Monitors are running everywhere. We already collect a lot of physiological signals. And alarms. Lots of alarms. Anyone who has worked in these environments will tell you many of these alarms are not clinically actionable. Alarm fatigue is a well-known systems problem. The issue isn't that we don't have enough sensors. The issue is that most monitoring systems treat each signal independently. But clinicians rarely interpret signals in isolation. They interpret patterns. Modern systems are very good at collecting signals. Increasingly, they are also very good at predicting risk. But there's still a missing question. How do signals actually turn into structured decisions? I ran into this problem while building a system for schools. In that environment, probabilistic interpretation could not be allowed to directly mutate the student record. The architecture I'm about to show you is essentially a consequence of solving that constraint. If probabilistic interpretations can't directly mutate state, what should sit between them? In the emergent state machine architecture, we separate layers that are collapsed in most systems. The signal layer is what we observe. The projection layer is how signals are interpreted. Authority is the rule or policy governing the decision. And the decision is the resulting action, for example, triggering an alarm. In this architecture, that sequence constitutes a turn. A turn is a single decision event in which signals are observed, interpreted, authorized by policy, and produce a decision. Each turn is a structured record of the decision process, which means decisions are transparent, inspectable, and replayable. In this architecture, the rules that interpret signals are called primitives. A primitive is a structured rule that monitors signals and decides when a concern should be raised. In clinical ESM systems, primitives are defined and validated by clinicians. Technologies like machine learning or generative AI may be used to identify candidate patterns in clinical data. But clinicians determine which primitives are meaningful and safe. Some signals are measured directly. Others are derived from relationships among signals. A derived signal is a computed observation based on other signals. It is still part of the observation layer, not yet the decision rule. Examples of derived signals include trend, ratio, and interaction. Clinicians often reason about how a signal is changing, not just its current value. For a ratio like shock index, this is not a new sensor. It is a new way of interpreting existing signals. Many clinically meaningful patterns are relationships between signals, not individual measurements. A derived signal helps us understand a relationship in the data. A primitive determines when that relationship should trigger concern. Another advantage of structuring decisions this way is that each decision only requires the evidence relevant to that decision. A respiratory primitive may evaluate a small number of signals. It does not require a medication list, imaging, a full chart history, every available variable. Structuring decisions into turns dramatically reduces the amount of data the system needs to consider at any moment. One way to think about the ESM architecture is as a set of small specialist decision systems. Each focuses on a physiological domain. Each evaluates a limited set of primitives. Each works with a small evidence set. Each produces structured signals when patterns appear. The respiratory stability ESM has a simple job. It continuously monitors derived signals like these. When thresholds defined by clinicians are crossed, it produces a signal indicating respiratory instability. The hemodynamic risk ESM monitors patterns related to circulatory stability. The sepsis pattern ESM detects patterns associated with infection. It's important to note that none of these specialist systems diagnose anything. They simply report when patterns of concern appear. A natural consequence of structuring systems this way is what I call instrumented deterministic evolution. It's instrumented in the sense that each turn records signals observed, interpretation applied, authority authorizing the decision. This means instrumentation occurs at the decision boundary, not only the sensory boundary. It's deterministic in that the same signals produce the same decisions. This means system behavior becomes reproducible. Evolution happens because primitives can be studied and improved over time. In other words, once decisions are structured this way, you can study your system scientifically. An ESM is essentially a small control loop. Because control loops can be layered, ESMs can be nested. That means specialist systems can produce signals, and those signals can become inputs to higher level systems. For example, the 3 specialist ESMs that we saw earlier may emit signals that feed into a patient state ESM, whose only job is to monitor instability signals and escalate monitoring as needed. As information moves upward, complexity is reduced in this architecture. Let's go back to the patient room. The sensors haven't changed. The monitors haven't changed. We're still collecting the same physiological signals. But the information presented to clinicians is very different. In most monitoring systems today, each signal acts independently. Each threshold crossing becomes an alarm. That creates a constant stream of alerts, many of which don't actually represent meaningful clinical change. That's the root of alarm fatigue. With an emergent state machine architecture, the system doesn't just report signals, it reports structured interpretations of patient state. These are not raw sensor alarms, they're signals produced by small, specialist decision systems that evaluate patterns across multiple observations. Each signal represents a clinically meaningful change in patient state. In other words, the system is compressing many raw measurements into a small number of interpretable signals. The goal isn't more alarms, the goal is better signals about meaningful change in patient state. Another important point is that you don't need to rebuild your clinical system in order to benefit from this architecture. Hospitals already collect most required signals, and because primitives are modular, improvements can often be made locally without redesigning entire systems. Here are 3 practical entry points. One of the earliest benefits may not even involve changing decision rules. It may simply involve observing how signals behave over time and in relationship to one another. Temporal patterns like these often become the building blocks of primitives that clinicians later encode into the system. Another simple step is to begin organizing derived signals like ratios more explicitly. These are often already familiar clinically. ESM gives them an explicit place in the decision architecture. Another early benefit is paying closer attention to interactions among signals. These interactions often become candidate primitives once clinicians decide they are meaningful and safe. In closing, AI tools can help discover patterns, but systems still need architecture governing how those patterns influence decisions. Emergent state machines provide a way to structure those decisions while keeping the reasoning transparent, testable, and improvable over time. Ultimately, the architecture comes down to a simple idea. Every meaningful decision happens inside a turn. Signals are observed, interpreted, authorized by policy, and then cross a boundary before mutating system state. This work is part of an open source project exploring emergent state machines. The ideas are still evolving. If you're interested in learning more, the repository is available online. Thank you for watching.